So another good morning, good afternoon and good evening to all. A very warm welcome on behalf of MYT, and we're very much looking forward to supporting you with today's session, Campaign Integration with PHC Systems. We'd like to open with a few housekeeping notes before handing over to Dr. Emmanuel Emukah. We're delighted to offer today's session in English and in French. You will see on the Zoom menu bar the interpretation button. Please select your language now. Please ensure that you select the English booth or the French booth, as we may receive questions across both languages. We will post reminders through the chat if you do miss this at the beginning. Please be aware that the sessions today will be recorded, and you'll be able to view the recordings after the event via the Health Campaign Effectiveness Coalition website. Please familiarise yourself with the programme, speakers, attendees and networking opportunities available on the virtual platform. All can be accessed from the navigation bar on the left-hand side of the homepage. We'd like to encourage interaction. Please use social media channels to promote and engage a wide audience with this event by tagging HCE Coalition and using the hashtag collaborative action. During the session, please add any questions you have to the Zoom Q&A, which can be found underneath the stream. You will be able to see the questions posted by other colleagues, upvote questions and add additional comments. We'll aim to answer as many of these as possible. And finally, the MYT team are here to help you with any technical difficulties. Please use the chat facility here on Zoom or email the team at events@myt.uk.com. I'm now delighted to hand over to Dr. Emmanuel Emukah to formally welcome you to today's session. So over to you.
Thank you very much. Good morning, good afternoon, good evening, everyone. You're welcome to this session F of the Campaign and Integration Effectiveness Campaign. Our session today, we focus on looking at health campaign inputs, processes, and resources, how they can strengthen routine services in the primary healthcare system. We have objectives to meet, and these are based on the promising practices that we are going to have from the presenters who have worked on campaign effectiveness programs. And then we also advise HCE on what next steps that they need to take. Joining me in this panel discussion will be Dr. Wafeu from the Center for Research on Filariasis and other tropical diseases in Cameroon. And also I have Dr. Toure Djeinam and Dr. Landry Cote, who will be, speaking on us on vitamin A supplementation. They are from Keller International and the National Nutrition Program for Cote d'Ivoire. I will also have Dr. Abel Eigege of the Cater Center, Nigeria, and Dr. Jude Winful-Orieke, the Delta State Primary Healthcare Development Agency. And our rapporteur today will be Emily Griswold and Jaden Gallagher. And of course, we have assistance from Carol McPhillips, who is a consultant to the HCE program. So I will go straight to the presentations, and the design will be that as each presentation is made, it will be followed by a question. I will start by presenting the Nigerian, program and the lessons we learned, transiting from government, from a transition to government ownership of schistosomiasis and soil-transmitted helminth control in 4 districts in Nigeria. Next. And we conducted interviews of health workers across the levels, and we had key, findings that we want to share with you now. First of all, looking at what we saw across the 4 districts, we found that the primary healthcare system our functionality is weak to moderate. And where the primary healthcare system is functioning very well, we saw a reasonable performance with integration, especially with my immunization program. And then the outcomes were good. There was good perception of the NTD program. And then also the collaboration between the primary healthcare system, Ministry of Health, and the education was good. However, on the contrary, in states where the Ministry of Health is anchoring the NTD program, we observed gap in communication, gap in knowledge, and also in collaboration. Especially it was disappointing, really, noting the reluctance of the Ministry of Health to even collaborate with the primary healthcare system, more or less Ministry of Education. And overall, we observed that too, that government officials required a gradual transitioning so that they will have more time to understand and grasp the process and concept. Next slide. We also intervened by distributing mebendazole, a deworming agent for the school-age children. I will take example from two local governments, Eigege and Ueli South. Eigege is in Edo and Ueli South is in Delta State. Now there are two, scenarios that we observe. We noticed that the school system that we plan to use to distribute the medicines closed, unexpectedly, and that resulted in some challenges in Eigege because the health system in Eigege is still, at the preliminary PHC system, so they could not continue the MDA. Whereas in Ueli South, we noticed that the health system there was resilient. The primary health care system was on the driving wheel. So the health system quickly used immunization strategies to implement. So the immunization strategies they used were outreaches, going to the churches, using their ward level committees as they normally do in immunization to reach out the children. And they used town announcements to gather the children to the health center. So there was a very strong connection between the community and the health system. Next slide. We had challenges while we were implementing, and overall, we noted that most governments were not ready to buy into the transition plan. And like I mentioned earlier, the communication gap is very huge in states where NTD is anchored in the Ministry of Health. And we also noted, disappointingly, that they don't want to collaborate with the primary health care and Ministry of Education. So those communication gaps really cause a lot of, setbacks. And we noted overall that the PHC system is not, functioning effectively in all the states. And we also noted that most states don't have budget lines for NTD, program. And that is mainly in those areas where the PHC agency is not, functional. And the NTD program depended 100% on partners. And if the partners pull out, the program goes. So we also noted the drug supply, issues, which remain intractable in Nigeria, and mainly because of accountability and reporting issues. Next slide. We try to prosper some mitigation, and one key thing that we noted was the fact that there is need to have an advocate that would speak to the highest authorities in the various states, that's the governors, their wives, and all the top leaders. The Cater Center normally does frequent communication with the Ministry of Health and the routine civil service structure. We are recommending that strategy should change and focus on reaching out to the governors and the commissioners and permanent secretaries. And we also felt that states need to have support to develop sustainable and integrated health plans that is costed. And we also expect that the health system needs to be strengthened. Human resource, is really lacking in most primary health centers. And then also, financing of the health system is also weak, and therefore we suggest that there should be, a design option for low-income countries for healthcare financing. And then also support development of a supply chain management system, because these medicines are not coming up due to inability to apply, report, and conduct reverse logistics. Again, we noted the weakness in the referral system that we need to improve, so that there will be good connection between the PHC, the community, and the higher level healthcare services. And of course, basic equipment is lacking and they need to be improved. And then we need to strengthen the feedback channels between government and partners. Thank you very much. So we will move on to take some questions that might come up in the chat. But really, what we have noted here is the fact that the health system needs to be strengthened. And one of the big lessons we learned is that for you to do integration, the primary healthcare system needs to be running. If the PHC system is not functioning, if you bring anything on top of it, it's not going to be sustainable. And then financing primary healthcare is also an issue where government need to have resources. So they need to think out, how best, opportunities will be given to harness, areas like health insurance, and then community health, insurance schemes that need to improve, the services of primary healthcare system. I will go ahead to, if there are no questions posed. Emily, did you catch any question that I need to address?
I've not seen any questions yet, Dr. Emukah. But I've got some myself, but I'll reserve them for the end. Let's continue with the next presentation.
Okay, good. So I will invite Dr. Wafeu of the Center for Research on Filariasis and other tropical diseases in Cameroon. And the question I have, for you to address is, looking ahead, what are the, promising, studies that you need to advise, HCE to conduct in the future, and what are those opportunities and that we need to do in health campaigns, integrating them into the routine primary healthcare systems. So if you can address that with your presentation, that would be fine.
Okay, thank you, Doctor, for giving me the floor. And thank you so much for this opportunity. My slides are in English, so I will be presenting in French. Okay, donc aujourd'hui, je vais parler donc des...
So today I'm going to talk about the opportunity at the community level for the integration of campaigns into the primary healthcare system. Next slide, please. So these are the three items I'm going to talk about during this brief presentation. First, the context in Cameroon and the ways we have to fight in Cameroon, and also the limits of these ways and what we have. Then I will talk about the preliminary results that although it is not complete yet, we still have some very interesting items and elements, very promising, that show that there are opportunities at the community level to to help with this integration, and then I will talk about what was asked to me, what are the research opportunities and what are the next steps that we can go through to have this integration that is a factor that will improve the efficiency of the campaigns. Next slide, please. So regarding the context in Cameroon, so Cameroon is an endemic country, as you can see on the picture, and it's also a country where we don't have a big coverage for the distribution of ivermectin. And in the 189 health districts, we have a coverage that is less than 80%. So the disease is still endemic in about 60% of the health district. And the prevalence is still high, up to 60% in some of the health districts. Regarding the control strategies, for the distribution and administration in ivermectin, if it could be efficient in certain contexts or countries, but in Cameroon, we've had several studies to know why there is a persistence of the disease despite the administration, and we found out that the main reason is a poor coverage, and 1/3 of the people who didn't get the medication, the administration, is because they were out of their own household, because in those rural areas, some people are gone for weeks or even months for their work, and so they were not home during the campaign. Next slide, please. So facing this problem and this lack, the question for us was to assess the opportunities for the challenges we are facing regarding the integration and administration and distribution. And here it is a partial integration, which consists in leaving the ivermectin available in health centers so that people who were not there, who were absent during the campaign, could, when they return, receive the medication, knowing that that would allow a bigger coverage and reduce the prevalence of the disease. And what we have done, we had interviews, namely in the health district of Yabassi on the coastal region. And what we saw is that first, many people were not available during the campaign. This is what came out during the studies. And we also saw that this campaign is about 1 to 2 weeks for the administration. And if you are not here, you are going to miss it. And during these interviews, we also saw that a lot of people, when they come back to the villages, they are going to go to the health center to see if the treatment is still available, and take it. And several health workers with whom we talked confirmed that a lot of patients come back after the end of the campaign to ask if ivermectin is still available and they can get it. And until the medication is sent back to the main center in the region and to the central health district, it can be distributed to people who can come to ask for it. And if it's no longer available, then they have to wait another year. And another opportunity that we found out about is the willingness of the traditional authorities to promote the health activities through integration. And we talked to a community leader that you see on the picture, who said it would be a very good idea to leave the drug at the health center so that people, when they come back, will be able to get it. And we see from this preliminary data that there are lots of opportunities at the community level to facilitate this integration for, in the end, increase the coverage, and we hope have a greater impact on the disease. Next slide, please. Next slide. And to finish, this preliminary data allowed us to suggest research ideas that could lead to the next steps. And the first item is one of the things we are working on is to complete the mapping of the opportunity at each level of the health system. And we talked about the community level, but it could be also regional and central level, so that the whole chain is taken into account, the whole supply chain is taken into account. But beyond opportunities, it would be useful to have trial to assess the actual effect of integration on the results of the campaign, knowing that they would have several tools that would allow us to measure the campaign, and it's also to assess the obstacle, the barriers, or the opportunities that there would be to integrate ivermectin to other activities and primary healthcare system. For example, integrated to vaccination, immunization, or routine visits, etc. So these are certain researches that we could do to increase the integration to the health system. Next slide, please. So thank you very much for your attention, and I'm open to questions if you have any. Thank you.
Thank you very much. We posed a question to you at the beginning, and I think from your slide, we have addressed them. So we are running behind. I think we'll have to go to the next presenter. Our next presenter is going to talk on evaluating the transition of vitamin A supplementation and deworming into the routine health system in Cote. So I'm inviting Dr. Djeinam and Laundry to please go ahead and make your presentation. And your question will be, what adjustments have you or the PHC system had to make that were unexpected while you were implementing the vitamin A supplementation? Thank you.
Thanks, Emmanuel, and thanks to you all. I'm delighted to be giving this presentation alongside my colleague Laundry on behalf of a big team at Helen Keller and the National Nutrition Program. I'll be speaking English, and then we'll transition to French about halfway through the presentation. Next slide. So the government of Côte d'Ivoire is transitioning to routine vitamin A supplementation from campaigns, but coverage has remained low. Next. So routine vitamin A is available in 3 ways: at a fixed distribution at health centers where parents are coming to get vitamin A, an advanced strategy where health workers are going out to communities and supplementing children within a radius of the health center, and a mobile strategy where stock is left with community health workers for them to supplement children on their own time. Next. So the government of Cote d'Ivoire adopted this transition plan in 2019, and since then 41 of 113 districts have transitioned. Next, but coverage rates, admin coverage rates have hovered around 30% on average, which is well below the mark of 80 that we're aiming for. Next slide. So with that as context, we conducted a study to understand the barriers to routinization and the transition to routine in 28 districts in Cote d'Ivoire. This barrier analysis is part of a larger piece of work to identify barriers and then to tailor strategies and pilot them as part of a randomized controlled trial. But I'll focus on the barrier analysis for this presentation. So we conducted 52 qualitative interviews with implementing partners from the national level all the way through district health officials and caregivers. Next, we also conducted a cross-sectional quantitative study. Next, with about just under 2,000 households and about 100 different health volunteers. And our work was guided by the Consolidated Framework for Implementation Research. Next. And so I'll hand over to my colleague Yaounde to provide some preliminary findings on the barriers as well as mitigation strategies for this work that we just completed in October. Over to you, Yaounde.
Merci bien, Djeinam. Alors là, à la suite.
Merci. Donc, so following this study, we have preliminary findings, and we're going to talk about 3 of them. And we're also going to talk about mitigation strategies. So first,
the first obstacle, the first barrier that was noted in our study is the inefficiency of the supply mechanism that we've been able to identify. So the furniture, the delivery in capsules is based on a number of targeted children. Next, so the supply capsule is based on the number of targeted children, and the problem that we've noticed here is that we have a dysfunctioning between the discontinuity between the data at the health center and the data, you know, of the children that are targeted in the district. So and that disconnection leads to underestimation of the data for supply and the data for capsules itself. Another point that we've noticed, next slide, is the problem with the tools to track supplementation, you know, are lacking at the community level, you know, to follow up on the supplementation work. You know, we have the registers, the books of follow-up, you know, so that it causes an under-reporting of supplementation and under-provisioning, under supplying, you know, and that is based on the problem of supply data, which leads to under-provisioning of the entrance at the level of health center or at a district level. And the third point that we noted, you know, in the delivery supply, you know, mechanisms, that 71% of the facilities are reported to be out of stock. 56% of health centers have declared that don't have the necessary tools to notify that they have supplementation issue, and 48% of healthcare centers have said that they have a problem of ability of the entrance. So you can see in the quote, you know, on the right side, you know, the agents, you know, have mentioned that for those who have been interviewed within the Cali aspect, that they mentioned the problem with the entrance, you know, and the fact that there's a lack of tools on the collection tools on the ground. Next slide. The second problem that we want to that we identify, want to share with you during this presentation is the communication strategy. So there's an inadequate communication strategy at healthcare centers. So you can see in the graphics, you know, see the availability of communication material and training for communication materials. So for nearly 50% of healthcare centers do not have any mechanism for reminding, you know, people that they need to get their second doses of women, you know, so they're targeting women that need to send their children to the healthcare center that need to get their second dose of vitamin A for the deworming. And for the middle graphic, we see that more than 60% of healthcare centers do not have any communication materials. So communication material, you know, aimed at strengthening the awareness of so that the household, you know, are encouraged to get the vitamin at healthcare centers. So the healthcare centers, it does not have this communication material to strengthen the activities, to mobilize the population and to talk about the importance of getting the vitamin A supplementation. And you know, and this third graphic that we see on the right side, you can see 64.2% of healthcare centers that have not been trained on communication materials. So on the next slide, we will see the motivations of health CHW. So we can see here that in addition to the support that, you know, for CHE, you know, that they need in the area of training and to get the constructive feedback to improve their work, there's the issue of financial motivation that you can see in the blue column. The data shows that even though they are motivated by motivated on the for the training work on the ground, you know, we need to incentivize them, you know, financially, and we also need to provide them, you know, the means of mobility so that they can do their work for the vitamin A supplementation, you know. So these are the three areas of the mitigation strategies that we have noted in these in reference to these three challenges. And next slide, please. You know, the strategy for mitigation that we have noted for these three areas. So we have need to address you know, out of stock issues. We need to train the CSW and provide them, you know, the necessary training and tools to report accurately on supplementation data. The second problem that we are identified, or second strategy, is to intensify communication strategy at community level and at all level until the peripheral level to ensure communications, continuous communication. And third point is to continue the advocacy for improved communication channel and continue to motivate CHW via supportive supervision and regular feedback. So for next slide now, for the next, you know, in our study, we are planning to finalize through the validation during the workshop of the result that we're going to share with all of the implementation actors according to the district or region and the financial and technical partners, and we're going to define the priority action to improve the coverage of the region and also implement, you know, local strategy to have in this area. So this is what we can share with you today in a concise fashion. Next slide, please. Thank you.
Thank you very much. I was trying to ask you to end, but there are questions that I've seen in the chat box and also in the Q&A. We will address these questions at the end of this presentation that Dr. Abel will give us. Dr. Abel, you are going to talk to us on mobility management for lymphatic filariasis integration into the primary health care in Plateau and Nasarawa states. Your question will be, from your perspective, what is your understanding on integration into primary health care using the MMDP experience in Plateau and Nasarawa state? The floor is yours, sir. Dr.
Eigege, we've got your pre-record for us to share, if you'd like us to.
I think he prefers that you play the pre-recorded.
Good morning, good afternoon, ladies and gentlemen. Lymphatic filariasis MMDP work, integration into primary healthcare services in Plateau and Nasarawa states of Nigeria, presented by Dr. Abel Eigege. Our MMDP timeline is as follows. We started collecting baseline data for lymphedema and hydrocele during our mapping and MDA activities in 1999 to 2000. Pilot hydrocele surgeries commenced in 2002 to 2005. Then we began the establishment of the Hope Group between 2003 to 2020. Active case search started in 2018 till date, and hydrocele surgeries commenced again in 2020 till date, largely due to the funding we received from Izumi. How did we do it? We identified cases by active case search, by CDDs and trained PHC staff and TCC staff. These cases are validated and assessed and registered at the PHC level. Then we selected the Hope Group facilitators and surgery teams and trained them. The cost is shared between TCC at 85% and State Ministry of Health 15%. We also provided the minimum care package and then the financing of Hope Group meetings. As mentioned before, assessment, validation, and registration were done at the PHC by the healthcare providers. It could either be a lymphedema case or a hydrocele case. If it is mild, moderate, it is managed at the PHC level. Severe cases are managed at the general hospital level and the tertiary hospital level. Similarly, uncomplicated hydroceles are managed at the general hospital level, and the complicated ones are managed at the tertiary hospital level. We also provided minimum package to care centers. These are basic equipment, essential drugs, and other consumables that strengthen the PHC services. These were made available and they were made also accessible, and they were quality basic care that were relevant and appropriate for the needs of the patients being helped. We acknowledge and appreciate here the pioneering work of late John Umoru in the lymphedema management cases in these two states. We also managed the lymphedema cases at our 20 centers that the 836 patients were attended to by our trained 95 Hope Group facilitators. Our surgery started in 2002 as mentioned, and it continued till 2021. So far, 815 surgeries in 625 patients between 2002 to 2021 have been done, going out 10 times to 6 rural hospitals. And during these campaigns, doctors are trained by consultant urologists. The challenges to MMDP are the COVID-19 lockdown affected availability of means of transportation. This prevented many of them from attending the lymphedema management sessions or the surgery sessions. Some patients didn't have enough money to transport themselves to and fro for the services that were provided. Sustainability was a major challenge, with the state ministries contributing only 15%. This certainly cannot sustain the program. And the frequent transfers of the trained MMDP facilitators to other clinics where these services are not provided was also a major challenge. Areas of research include sustainability researches, health system strengthening, cost benefit of integration, and impact of COVID-19 on cost benefits of integration. I want to thank Izumi and other corporate and individual donors. I want to thank you for your attention.
Yeah, thank you, Dr. Abel. Can you take a few minutes to address the question on integration, the perspective based on what you experience in integrating mobility management in Plateau and Nasarawa State.
Integration, as defined by Salinsky et al., is a strategic alignment of program resources in such a way that it increases effectiveness and efficiency of and that the programs that are in partnership, the integrity of their objectives is never compromised. So we are coming back to a place providing the services together, ensuring that staff are trained, strengthening logistic aspects by providing needed resources, as I've mentioned to you. So in essence, you do training, you strengthen the logistic chain, you also provide resources like financing of the program. Plateau and Nasarawa, supported by TCC, has demonstrated many areas of integration. We've done that for malaria and LF. We've done that for LF Onco. We've done that for LF Onco Schisto. So the integration are mirrored. Even we have done LF Onco and trachoma. In essence, the services will be provided in one place, under one roof. And take, for example, like MMDP aspect. In the process of screening, the pre-ops, you could find somebody who has hypertension. You could also find somebody who has diabetes. All these can be treated within the same place. While we're dealing with high-risk cases, we also found high-near cases that were routinely repaired. And when dealing with lymphedema, you could also find somebody with podoconiosis, and these were given the necessary help that they needed. In essence, this is what our integration is in Plateau and Nasarawa. Thank you.
Okay, thank you very much. I would have asked you more questions, but let's also catch up with our panelists from Delta State, the Executive Director, the Permanent Secretary of Delta State Primary Healthcare Agency. I want to ask him to share his experience, establishing integrated primary healthcare program in Delta State. What are the best practices that he observed or learned, and areas that further support?
Thank you very much, Emukah. Thank you, Dr. Louise. In Delta State, the integrated mechanism is in place.
We can only hear you very quietly. Would you mind coming off mute? And
because the primary care development agency was established just for the purpose of integrating primary care services. We have a lot of programs, organization, nutrition services, NTD, part of it. Also, maternal and child health care, primary care level, all integrated, family planning, all integrated into the state primary care development agency. And it has been very profitable in terms of resources, leveraging resources, in terms of getting enough to get the processes, especially at the community level, open. So the benefits, again, it improves governance of the system when all the programs are integrated. And it's very good for resource constrained environments, like what we have in many African communities. It also helps us to strengthen the health institutions. The workers are better trained and able to cope with the services which they encounter, which they have to produce, and health centers. It also helps us to leverage on service provision at the community level, especially at the household level. We focus more on that level to ensure that people have the capacity to prevent simple diseases. And that is what we actually do. And talking about integration is very necessary. In my state, we leverage on the various programs to ensure that we don't have vertical processes. Vertical processes have a lot of disadvantages. A lot of resources are wasted.
Dr. Winful-Orieke, we can't hear you. Would you mind coming off of mute?
Hello?
You say you come off mute. Are you muted? Check.
That thing has to be turned off because
It's
the transfer.
Can you hear him?
Yes.
So, very sorry. Let me start with when we talk about retail services in Delta State, I said that the Delta State Primary Heritage is the official program for integrating primary heritage. And we are going to strengthen routine service delivery. The agency has a structure at the state level that coordinates the various activities at the local government level. At the local government level, we also have a structure that also coordinates the community and ward level activities. Of course, we focus more on the households to ensure that the people are able to have enough capacity to prevent basic illnesses. And in fact, that is what we do. We try to ensure we integrate our services and reduce, we leverage the resources that we have to ensure that we have more resource and hit our targets for various programs. Thank you.
Thank you very much, Dr. Jude Winful, for sharing your experience. We are running short of time, and there are questions that I have seen in the Q&A and then also in the chat. The first question on the Q&A that I have seen is asking the presentation that I gave, what role do other health workers who are not primary health care have, with the program and also with the community? For the integration concept, we talk about collaboration. So those officers who are not primary health care officers in the ministries of health, they collaborate. Most of the time when campaigns are done in each state, they pull staff from both the primary health care and also from the Ministry of Health to participate. And then we also collaborate with the Ministry of Education, that control the teachers that are the distributors of the deworming medicine. So they come in there. Oftentimes we have the office of the first ladies also carry out deworming campaigns. So their staff are also used in the process. And then looking at the other questions of what other platforms that were used in the apart from immunization, like the Dr. Winful mentioned, we have the maternal and child health program. That is an opportunity for integration. We have malaria net campaign upkeep. We have the malaria treatment opportunities that they also do in the community. We have the school health services program and the school feeding program that were opportunities for integration of the deworming program in the communities. And at every community level, we have structures there on ground, that the ward development committees, the town announcers, the village leadership, all of them play significant roles. And of course, we have the pool of our human resources in the communities. The community directed distributors also are available to support the processes of integration in the primary health care. So at the community level, the structure is very strong. Then at the health, primary health care is where there are challenges also because of manpower, issues, training needs, and then financing also to keep them working. And I believe in places where the primary health care system is functioning well, they are gradually addressing these areas. I have noted some questions also for, if time permits, for Cote d'Ivoire. I don't know, somebody asked question on vitamin A. Yes, he said the supplementation program has been implemented in Cote d'Ivoire for well over 10 rounds or more. That is 15 to 20 years. The preliminary findings reported supply issues, and the questioner asks that is curious to if these have been chronic issues that have been unresolved, that is the supply chain issues with vitamin A. So maybe Dr. Djeinam, you try to respond to that issue
quickly.
of
Thank you,
supply
Emmanuel.
of vitamin A.
So Ralph, you'll see a written response. It's an excellent question. I think
From
the
your
specific issues that
perspective.
we highlighted are
Just have a few minutes to do that.
Are specific to routine vitamin A supplementation, which has been implemented for about 3 years. So I don't think those issues are as much of a problem for campaigns. And my colleague Yaounde added.
Unmute yourself so that we can hear you.
Can you hear me? Did you hear my response?
I can hear you. I think Dr. Emukah can't. Go ahead, Dr.
Okay,
Toure.
that was all. Thank you. If everyone heard, if Yaounde wants to add, go for it.
Doctor.
Puisse arriver à mettre à disposition les intrants. Mais il en demeure toujours un problème sur lequel nous travaillons,
Thanks. Back over to you, Emmanuel. Merci, Landry.
Dr. Emukah, could this be the last question, just so that we can move over onto the networking very shortly?
Okay. I don't think I've seen any further questions from there. Okay, there's one question by Don Hawkins who asks, what has immunization benefited from the integration that we experienced in Delta? I think that is a question I will refer to the primary healthcare in Delta State. Dr. Winful, can you please elaborate on if immunization benefited from the integration of schistosomiasis program in your local government? Few minutes.
Thank you. Support in terms of supervisory support, technical support, and also material equipment support. So most of the programs, when integrated with the immunization program, the coverage is much better because the structure for immunization is so strong, widespread across the communities. For every ward, there's a functional primary care center, and these centers are also involved in outreach programs and community outreach. Most times just twice a week, but that's enough. When the people know that the team is coming, they'll be there to receive them and present their problems. So there was a campaign we did that we integrated vitamin A, that's the measles campaign, and it was quite successful. That was some years back. The vitamin A coverage was very good. So immunization as a program actually works very well when it's integrated with other programs, especially programs that have some programs that have the same goal in terms of coverage and target population. For example, under 5 children, if you have that same target, you'll be able to get more efficiency in the output of your program. So for the entities also, for the school soil transmitted helminths, the immunization program is also good in terms of integrating both as their school children, especially when you want to give, for girls now, HPV vaccine, and then you are integrating the school-based soil helminths infection prevention. So it's quite good that we have that. So thank you very much for having me.
Thank you very much.
We are behind time. So I want to invite Emily to just give us a synopsis of what we have done, and then we close.
Thanks, Dr. Emukah. I believe we've answered the majority of the questions. If you want to continue the discussion, and I would recommend that you do, Claire will direct you to the net. There's a discussion section for everyone to keep talking about these issues. Thank you so much.
Thank
Claire,
you
go
very
ahead.
much. So thank you again to all of our speakers and for Dr. Emukah for moderating a great session. As Chris mentioned in the opening plenary, please join our networking session. So we'll be using AirMeet as the networking platform. So click on the program tab and go to the networking and join AirMeet. We'll also just post the link in the chat just now for you so that anyone can just follow it straight through from the session today. Once you're in the platform, you can either join the general discussion or you can join tables based on the poster presenters which are on the platform. We'll also be opening day 2 with AirMeet at 7 AM EDT for our breakout sessions begin at 8 AM EDT. So thank you again to all our speakers and our moderator and the interpreters today, and we'll see you in AirMeet in a few moments. Thank you very much.
Thank you.